Herpes Congress. So for those who thought you're going to have a lot of talks on hyperglycemia and pregnancy and need a break, then this is the session to sit in, because I'm not going to speak about anything connected with diabetes and pregnancy. And my conversation is on a very important topic in general, which is herpes zoster and its preventability. So let's look at this discussion with some real world evidence. This is supported by GSK, and I'm speaking on their behalf here. The world is clearly aging, and there's a projected increase in population over 60 years of age. India is undergoing a rapid demographic transition, with the elderly population projected to more than double from 100 million in 2011 to 230 million by 2036. So we really need to have measures to take care of our aging population. The interplay of aging, chronic disease, and infection susceptibility is very interesting. As one ages, there are biological changes with the age. There is more inflammation, there is immunosenescence, microbiome imbalance, and gut barrier decline, which increases not only the risk of multi-morbidity as we see in our aging population, but also that of cardiovascular disease, diabetes, osteoporosis, cancer, arthritis, and so on. This also leads to poor treatment response to most of the therapy and the risk of polypharmacy. There's increased side effects, less effective therapies, and reduced quality of life, increased infection susceptibility, and higher, of course, healthcare cost and the burden. So aging, comorbidities, and the growing threat of vaccine preventable diseases, what is referred to commonly as VPDs. There are key drivers behind the rise of vaccine preventable disease in India's aging population. One is the term, as I referred to, which is immunosenescence, which is your reduction in immunity. There is an age-related decline in immune function, which increases chances of infections like influenza, herpes, and so on. Importantly, there's reduced vaccine efficacy in older adults. The age or aging itself reduces response to standard vaccine, requiring the need for boosters or stronger formulations, including the need for such vaccinations in people who already suffered from the disease. So one of the commonest questions asked is, I've already had herpes, doctor. Do I need this vaccine? And the answer is yes. Even if you've had herpes, this vaccine is recommended above the age of 50 because the chances of reinfection. There are, of course, different guidelines. The CDC from the US says soon after the acute symptoms are over, during an attack of herpes zoster, you can be vaccinated. The guidelines from Canada talk about 1 year after the disease. We don't have India-specific guidelines on the same, but these are the guidelines which say the need for vaccination even in people who had herpes. There is increased burden of comorbidities, especially chronic presence of COPD, asthma, and so on, waning immunity from your childhood vaccination, and clearly for many of us here, physicians, too, and the larger population, the concept of vaccination is restricted to childhood vaccination. So the term adult vaccination is not very well known and accepted across India, and hence a stronger need to create this awareness. There is very poor adult vaccination coverage, and the epidemiological shift due to better childhood vaccination, the chances of landing up with these diseases in adult life, especially as you go beyond 50, is much higher. There is a bidirectional link between comorbidities and vaccine preventable diseases. Chronic diseases increase the susceptibility to these VPDs to nearly 60% of total deaths annually in India. Common comorbidities like cardiovascular disease and renal disease heighten the risk. So let's look at the risk of herpes zoster in patients with comorbidities. And when you look at the multiple studies done, especially in patients with diabetes, COPD, asthma, chronic kidney disease, and cardiovascular conditions, is overwhelming, clearly establishing the higher incidence of shingles or herpes zoster in patients with these comorbidities. There is increased risk with multiple comorbidities and aging. You look at patients with diabetes and cardiovascular disease, there's a much higher score, diabetes and heart failure, COPD and diabetes, COPD and heart failure. So the risk of herpes zoster appears to increase with age and multiple comorbidities. So higher the age and more the comorbidities, there's a higher susceptibility to shingles or herpes zoster. The association between diabetes and herpes zoster specifically can be attributed to the immunological dysfunction, reduced cell-mediated immunity in diabetes, and hence higher susceptibility to zoster. There is some interesting medication-linked risk, especially in patients who are on glitazones, alpha-glucosidase inhibitors, and DPP-4. There seems to be a higher risk. We don't know the exact connect, but patients with diabetes on these drugs, especially DPP-4 inhibitors, we know its impact on the immunity and higher risk now of herpes zoster. Does that mean that we don't use DPP inhibitors for our patients? No, but it's just an aspect of slightly heightened risk there. The post-herpetic neuralgia is the most limiting or problematic factor from herpes for our patients. Patients with diabetes have increased severity and chronicity of post-herpetic neuralgia, and of course the increased burden, the healthcare burden in diabetic patients with herpes zoster. So I'm going to show a couple of real-world cases from across India, contributed by physicians who've come across this and have shared the cases with us. The first case is by Dr. Vipul Khandelwal, a consultant physician from Jaipur, and I'll be sharing his case shown here. So this is a case of herpes in couples. So this is not unknown. Somehow you do see this very often, that a couple, a susceptible couple, very often landing up with this kind of a case. So this was a case where a 60-year-old male, 56-year-old female, mild diabetes controlled on oral medications. The male lands up with a painful rash, burning sensation, unable to perform the routine daily activity. The female has painful blisters, tingling, electrically current-like sensation, unable to perform daily activities. The diagnosis was of clinically distinguished lesions of zoster, as you can see, largely on the back and just around the buttock area. Both patients presented with a classical picture of herpes. An interesting and unusual aspect of this case was the simultaneous reactivation in both the husband and wife. In the male, the disease began with unbearable neuropathic pain, followed by appearance of a unilateral vesicular rash, which is characteristic of zoster. In the female, similarly, the disease started with localized pain, progressed to a rash accompanied by fluid-filled blisters. The impact was pain persisted after the rash dried, and which we know is the rash will dry up. But the larger problem is the pain and the post-herpetic neuralgia, difficult managing daily activities, and emotional discomfort due to the painful sensation after the rash and the blisters disappear. The patient was given valacyclovir 1 gram TDS initiated on day 1, along with pregabalin once daily for neuropathic pain. The rash resolved. The pain persisted but gradually improved. There were treatment challenges, and the key takeaways from this case was that diabetes does increase the risk of herpes zoster. Vaccinations prevent the herpes zoster complications, and early antiviral treatment is essential. So at least here, the couple did present and was started on the antiviral on day 2, day 3, and did respond to the same. But the fact that this, the important aspect in the history which we said was that this couple both had so-called mild diabetes on oral medications. So is vaccination only for somebody with uncontrolled diabetes and severe kind of diabetes? No. So their susceptibility to infections like herpes, the fact that you have diabetes just increases the susceptibility, nothing to do with how well controlled or whether you are on insulin or orals and so on. Post-herpetic neuralgia risk across diabetes types, and here you're looking at patients' diabetes, comparing them to non-diabetics, different kinds of diabetes, age groups, sex. Across the spectrum, you're again seeing that compared with individuals without diabetes, those with diabetes had a 1.54-fold higher risk of developing post-herpetic neuralgia at ages of 60 and above. So post-herpetic neuralgia, again, repeat, is the problematic zone, and it increases in patients with diabetes. We'll move to our second case, a diabetic patient with painful post-herpetic neuralgia case shared with Dr. Sanjoy Ghosh, a consultant dermatologist from Kolkata. 61-year-old male, uncontrolled type 2 diabetes, controlled hypertension. Elderly individual was the risk factor. Develops left-sided chest pain for 4 days, followed by rashes with pain on the anterior and posterior side of the chest. Unilateral grouped vesicular lesions, as we can clearly appreciate here. The diagnosis was clearly herpes zoster. This was late presentation, 6 days post the eruption. Patient landed up with the dermatologist, had by then applied various creams, including topical steroid creams. Again, a very, very common aspect. Sometimes patients would send you a picture or ask that I'm getting some boils, what do you apply? And a typical steroid cream or a combination of antibiotic, antifungal and a steroid cream in the market will be applied. So if the diagnosis is not done in time, it would lead to problems. Secondary infection, poor glycemic control, again leading to delayed healing. Severe pain continued for more than 3 months. And this post-herpetic neuralgia for patients like these becomes a nightmare, and they keep cursing themselves and everybody around as to what they have landed up with. Disturbed sleep and quality of life severely affected, unable to maintain normal social and professional life, and developed scars due to the late treatment offered. Patient was given valacyclovir, again 1 gram TDS for 7 days, but this was started on day 7 as the patient presented late there. Was given gabapentin for the relief and some silicone gel for the scarring. The challenges were late initiation of antiviral, poor glycemic control, treatment adherence difficulty, persistent pain and mental distress. The takeaways again was identify herpes zoster risk factors and try and vaccinate your patients to prevent herpes. Manage the comorbidities alongside herpes zoster treatment, and early antiviral therapy prevents the chances of post-herpetic neuralgia and its complication. Case number 3 is varicella zoster virus reactivation presenting as facial palsy in a hypertensive male. Study by case shared by Dr. Umang Agarwal from Mumbai, an infectious disease specialist. 67-year-old male, known case of diabetes and hypertension, fluctuating blood pressure. 1-day history of left facial palsy, blisters in the ear and headache. Recent onset burning sensation in the ear, uncontrolled hypertension. Patient had, during the workup, even an MRI done, had evidence of meningitis, and the CSF revealed presence of herpes zoster virus. The disease course and challenges, diagnosing herpes zoster with neurological manifestations. So everybody with a facial palsy, it's not going to be because of herpes, but it's one of the things to rule out when your patient lands up with palsy. Patient was started with IV valenjocyclovir 10 milligram per kilogram TDS on day 2 of the illness, later on shifted to acyclovir. Headache improved, blisters crusted by day 5, steroids were administered for the 7th nerve palsy. Some may question its efficacy, but it's one of the treatments used for the Ramsay-Hunt syndrome. Responded to treatment, no long-term nerve damage, no post-herpetic neuralgia, no secondary infection, but did develop later acyclovir-induced acute kidney damage and had to be re-hospitalized and managed for the same. So huge financial and emotional burden. So the learnings from this case was hypertension and diabetes in elderly are risk factors for herpes. Burning sensation, headache or acute facial palsy may precede the onset of blisters. So be on the watch out in those cases. Acute facial palsy plus vesicular lesion, suspect varicella zoster. Offer shingles vaccination to patients at more than 50 years of age who are at risk. Awareness among primary care clinicians needs to improve to try and offer this vaccination to the population at risk. Case number 4, herpes zoster in a diabetic patient with cardiovascular disease. A very interesting case again, shared by Dr. Varun Sundamurthy from Coimbatore. 50-year-old male, known case of diabetes, uncontrolled, A1C at 10%, pre-existing coronary artery disease. Peasants with fever, myalgia, right-sided chest pain and chest discomfort. Develops a rash at the right-sided T6 dermatome with some secondary generalization. Patient is diagnosed to have herpes based on that classic blisters and presentation. Given valacyclovir, again 1 gram TDS for 7 days and discharged. Unfortunately readmitted on day 10 with an ST elevation MI as seen in the cardiogram attached. So acute STEMI, left ventricular dysfunction and volume overload due to the pre-renal acute kidney injury. Patient was evaluated, showed an LAD disease, more than 90% occlusion. Patient was already in florid failure. They had challenges in shifting the patient to the cath lab for further management, which had to be managed later after the left ventricular function improved. Patient on dual antiplatelets, the rash gradually resolved over 10 days. The disease impact was disfigurement, cardiac complications, financial burden, depression, and so on. So the key learnings from this case is poorly controlled diabetes is a significant risk factor again for herpes. Herpes, unfortunately, can lead to serious cardiac complications within 1 to 6 weeks of the infection. Now, these are things that we normally don't pay attention to, and we would look at it as just herpes, partially treated, let it be, and so on. So early identification of risk factors and timely vaccination are essential to prevent the long-term complication. Impact of herpes on cardiovascular disease: 30% elevated cardiovascular risk results from shingles. 25% elevated coronary heart disease risk was observed. 38% elevated stroke risk occurs after shingles, associated with permanent pacemaker placement for complete heart block, and there is also a possibility of varicella myocarditis. So there is this strong association between herpes and stroke or coronary heart disease. Sorry. So risk of myocardial infarction and stroke within 1 week of herpes in patients with existing CVD. There's been a self-controlled case series designed to study this. There was an observation period, then herpes zoster diagnosis, and then the end of observation time. And what they found was that the risk of MI within 1 week of herpes zoster diagnosis was 1.7-fold higher. The risk of ischemic stroke within 1 week of herpes of the zoster was 2.4-fold higher, the risk of ischemic stroke. So both these problems can happen within the weeks of varicella zoster, and that needs to be paid attention to, or rather prevented, by offering your patients vaccine. So the need for herpes zoster vaccination in adults with comorbidities: well, its recombinant vaccine outperforms the attenuated vaccine, providing a strong and lasting defense against herpes for up to 11 years. Helps to elicit an early, high and long-lasting immune response with less antigen. 2 doses of the recombinant zoster vaccine for the prevention of shingles and related complications in adults more than 50 years of age who are immunodeficient or immunosuppressed because of disease or therapy. So every individual with diabetes, hypertension, coronary heart disease, COPD, asthma, all of them qualify as those who are immunocompromised. The second dose, importantly, of recombinant zoster vaccine should typically be given within 2 to 6 months after the first. As the awareness is improving, this is my personal experience, we've been using the vaccine for a while. Unfortunately, a lot of patients either do not come up on time in spite of reminders, or refuse to take the second dose. And that's a problem, because unless you get the second dose within the time, you're not getting the desired immune antibodies and the response. So the efficacy, when you look at for the vaccine in different age categories: 50 to 59 years, it's 96.6%. 60 to 69 years, 94 to 97%. More than 60 years, 89 to 97% efficacy of the vaccine. The safety and immunogenicity in Indians aged more than 50 years. So vaccine response rate for the zoster antibodies at 1 month post the second dose, they found pre-dose 1, 97.6% of the participants in the RZV group and 96.9% participants in the placebo group were seropositive for the antibodies. So to remind the schedule: primary vaccination schedule and initial dose followed by a second dose after 2 months, or anytime between 2 to 6 months. If flexibility is needed, you can administer the second dose 2 to 6 months after the first. So very often, especially for those of you treating diabetes, if typically your frequency or schedule is 3 monthly, your patient has taken the first dose and doesn't want to come down specifically to the clinic for the second dose, we'll do that during the next follow-up visit, which is typically after 3 months' time. So Shingrix is indicated for prevention of herpes zoster and post-herpetic neuralgia in adults aged 50 plus years in patients with diabetes. I think that's still a limitation. You will have many patients at 45, 46 with history of diabetes for 10, 15 years, immunocompromised, who may benefit, but that's an off-label indication. As of now, clearly the guidelines recommend 50 years and above for this vaccination. Shingrix has an established safety profile. Most vaccination reactions were mild to moderate. So when you talk about pain at the site, fever, swelling, It's not something which is bothersome, and it's parallel to any other vaccination that we are using for the adults. Storage and administration: do not freeze. Supplied in 2 vials for reconstitution and intramuscular injection only. Contraindications are hypersensitivity and not indicated for primary varicella infection, which is chicken pox. Co-administration of shingles with other vaccines is possible, whether it's pneumococcal or influenza. It can be co-administered with the same. So with that, I hand it back to the chairs. There are current guidelines and recommendations in India essentially supporting the same aspect, from multiple societies strongly recommending Shingrix vaccine as part of the vaccination schedule, including our own RSSDI itself. So with that, thank you once again for having me here. Shingrix is approved in 61 countries with multiple doses and widely available across India. Thank you.